Good evening and welcome to my YouTube channel Pain Free Partha. Today I'm going to tell something about preemptive analgesia. Okay, welcome and wishes from our university, Balaji Vidyapeeth University and Mahatma Gandhi Medical College, Pondicherry, and our Director of E-Portfolio, Professor Ravi Shankar, was given all the advice. And welcome to this channel. Now, what is this preemptive analgesia? The original definition is simply you administer a painkiller before a painful event. That is all. Before the knife, you give the painkiller. That whatever be the painkiller. So what does it do? It reduce or prevent post-op pain and the development of chronic pain. So there is a separate slide for me in painfreepartha.com. Transition of acute to chronic pain. How does it happen like? Preemptive analgesia refers to the pharmacological interventions initiated prior to inhibit nociceptive mechanisms. So, for example, now you give a painful stimulus. There are certain mechanisms which are triggered. Needs to be, before that you need to give the pharmacological intervention. The first time it was said that if you the original nociceptive stimulus in research was the rat tail clamp test. So the pain caused by the clamping of the rat tail. Now, if you give morphine, they said the rat needed only 1/10 if you get after the tail clamp. So that is the concept of preemptive analgesia. Now, Craig's theory of Anosi association. In 1914, you see, 1914, what it described was this is the patient. He has input from eyes, nose, ears, everything. From here, everything. Here also there is a trauma which gives nociceptive impulses. Now, if you give general anesthesia, all these things are blocked. You can see all these things are blocked, but the trauma, pain, this is there. But you give a local anesthetic here, this is also blocked. This is what he said. The short-term exhaustion could be prevented by blocking the noxious stimulus from reaching the brain. So that is what he told opioids, agent, and local. This is Craig's theory of Anosi association. Harmful stimulus. That is what is called Anosi association. He was a great person. Here there is a scar. Scar means what everything is healed, but it is painful. What he said was, there is nothing here, something in the brain. That is what he told. Right in 1910, the 64th anniversary in 16th October 1910, he discussed the role of summation of repeated noxious stimulus. Where should the summation occur? It should be a central mechanism. That is what he told. The scar which is painful becomes central. This is the Craig's theory. Now we will go to preemptive analgesia as three objectives. It has been routinely told. Activation of incise, the inflammatory mechanisms should be stopped. To stop the pain memory response of the CNS, you have to have a good control of post-op pain so that there is no development of chronic pain. These are in the mind of a person who is going to inject the preemptive analgesic. So what is this pain memory? So the body remembers the painful experience and reacts to it. It's a nervous system response to injury. So there are so many pathways here so that the memory of a painful experience is there. What does preemptive do? Preemptive decrease the memory response. Now, what is normal? There is a transduction, transmission, and perception. Now you have an injury here or an incision here. It goes through this. This is a transduction. It converts into electrical energy, transmits, and goes to the opposite side. From there to the thalamus, and from there to the brain. There it is perceived. It is very well known that this pain can be blocked by NSAIDs here, and because here the prostaglandins are important. Modulation in the nerves blocks can be given. Local anesthetics, peripheral, epidural blocks, or there is maybe some influencing the descending inhibitory fibers, or if you parenteral opioids, GA alpha 2 agonist affecting the brain. Now we will go, already I have a slide on central sensitization. We will just start this. Now you have a stimulus. What is the pain intensity? This is the normal. Blue one is the normal. Now, okay, the blue one is the normal. Now you get 4 or 5. The stimulus intensity of here. This is where the pain is. Okay. So now at this, here the same point, the pain response is here if that is hyperalgesia. Hyperalgesia means painful stimulus, there is more pain. That is what is hyperalgesia. Hyperalgesia means more pain for the same painful stimulus. Now we can see allodynia. Allo means touch, dynia means pain. It's a non-noxious stimulus, non-painful stimulus. If you get pain, then it is called allodynia. Now we can see here in this graph, this up to this stimulus intensity, there is not much. Here the patient is having pain. Here they see here, the stimulus intensity is so low, the patient is having pain. This is allodynia. All these things happens because of sensitization, because of repeated bombarding by the nociceptive input. The peripheral sensitization refers to increased responsiveness. We can always see many times. The injury is here. Sometimes if you touch here also there will be pain. Touch here also there will be more pain. There will be painful stimulus is also increased. There are so many chemicals involved in this. Acetylcholine, G-related, substance P, bradykinins, histamines, nerve growth factors, and prostaglandins. So if you cut down this prostaglandin, possibly there may be a decrease in the peripheral sensitization. Peripheral sensitization means that occurs at the site of injury here. Central sensitization was first described by Wolf. In 1983, he said what happens is he had a stimulus, okay, and after that, what he developed an animal model. What happened was, after a peripheral injury, the flexor response was not good in that animal model. So what he said was, there is something wrong with this because of the peripheral injury. Something wrong has happened into the CNS, which causes the flexor response to be less. Now I have a fantastic photo here. This is the surgery, and this is the post-operative period. This is surgery and the post-operative period. Duration of surgery is in gray. Now, a surgical and post-operative afferent input. Now, after some time, you get hypersensitivity like this. Now, if you have post-surgical anesthesia, you have given anesthesia after the surgery. Now, you see here, the hypersensitivity is here, and the duration of surgery after that, the nociceptor input is continuous. Post-operative period, pain is continuous, and you are targeting this by giving some epidural or some tramadol or some aceclofenac. The hypersensitivity is less. This is about post-surgical. Now we have a pre-surgical. For example, you have topped up an epidural before the incision, 5-10 minutes well before the incision. This is gone, and you continue this thing, and the nociceptor input is still less, and the hypersensitivity is less. Now, what we need to do is we put an epidural, give intra-op, give pre-op, give intra-op, and give post-op. Here also the nociceptive input is fixed, so the hypersensitivity chance is less. That is what is needed. Preoperative epidural, intraoperative epidural, and postoperative epidural. Whatever it is, we are going to give analgesia means you start with injection ketorolac, dexamethasone preoperatively or fentanyl preoperatively, and continue fentanyl infusion intraoperatively and postoperatively, and follow up with ketorolac and paracetamol for this input. This is Descartes in 1644, cortical reorganization and central sensitization. What happens here in central sensitization, I'll tell you in the next slide. So many inputs. Development or increase in spontaneous activity. The spinal cord itself throws some electrical activity. Now, if a peripheral stimulus comes, the threshold is less, the spinal cord responds fast. Enlargement of the receptive field, conversion of nociceptive specific neurons to WDR neurons, wide dynamic range neurons, now responds to innocuous stimulus. See, now the spinal cord, there is only small space here, which responds to a peripheral stimulus, Now this is widened like this. This is widened like this. Now, if you touch like this also, if you give a painful stimulus by the side of the injury also, because the receptive field becomes wide in spinal cord. The receptive, this was before. After repeated stimulus and hypersensitivity, the central nervous system becomes like this. There is a wide dynamic range neurons. The receptive field has become bigger. Also known as they call nociplastic pain here. Nociplastic pain. This is what reduction in the neuronal activation threshold, increased pain intensity, even descending inhibitory inhibition is decreased, increased synaptics. So many things has happened. So that is what the problem was with central sensitization. The problem here and the problem here. Mostly what they say is physiological pain will not have much of hypersensitivity and goes on to get chronic pain. We have never heard of labor pain, and this labor pain has gone on to become chronic pain. This is physiological pain. So only the pathological pain with numerous algogens, what they call is algogens. Algesia means pain. Algogens means chemicals that produce pain. So many things. Repeated stimulus, central sensitization, wide dynamic range neurons, and we have a pathological pain, chronic pain, hypersensitivity, everything. Preemptive analgesia, treating post-op pain by preventing the establishment of central sensitization. Now there is a confusion. Now we are doing spinal anesthesia, epidural anesthesia alone. Is it a form of preemptive analgesia? I feel it is yes, because we are using a pharmacological intervention like local anesthetics into the epidural or spinal. That is what is the thing. But routinely, only one textbook describes this. One textbook describes this. What are the advantages of spinal anesthesia? It describes. First advantage is preemptive. Second advantage is intense intraoperative analgesia. Third advantage is early post-op analgesia. These were the advantages given by one of the textbooks, which is old. And so I describe the spinal or epidural is a form of preemptive analgesia. Now, what are the strategies? Yes, we know preemptive analgesia means before the surgical stimulus. We can do so many drugs. We can give ketamine, dextromethorphan, epidural local, epidural dexmed, epidural clonidine, epidural opioids, systemic alpha-2 agonist, systemic clonidine, systemic dexmed, systemic gabapentin. So many drugs are there, strategies. There are preemptive blocks, paracervical, pudendal, preemptive ibuprofen, preemptive ketorolac, preemptive dexamethasone, preemptive paracetamol. Many times you can see by giving dexamethasone with ketorolac just prior to start the case. So, or sometimes I will tell later. So that is one of the causes, strategy for preemptive analgesia. You give fentanyl, you give paracetamol and dexamethasone, or you give fentanyl, push up an epidural and give dexamethasone. Yes, dexamethasone, epidural, gabapentin, ketamine. This is balanced preemptive analgesia. Start with top of epidural, give oral gabapentin, start injection dexamethasone. Another 10 milligram or 15 milligrams of ketamine, NMDA antagonist is very good as a preemptive analgesic. So we may need to wait. That is very important. Because if you give top up of epidural, when the incision is put within 5 minutes, no use. We may need to wait. Ketamine we have given, epidural we have given, dexamethasone. Wait for 10 minutes. Let it act and then start putting your incision. Now we can see here, local, here the trauma is there. It goes through a peripheral nerve into the dorsal horn, goes opposite side into the thalamus and the brain. Now there are innumerable local anesthetics, anti-inflammatory. Here local anesthetics, epidural, spinal, opioids, alpha agonist, everything, and here also alpha agonist, opioids, everything, and dexamethasone as anti-inflammatory drugs. And ketamine can cause thalamocortical projection system, NMDA antagonist. Here we have a study of Parthasarathy, as you can see, acupuncture, a preemptive analgesic technique. What we did was, in the preoperative room, we did acupuncture for hernia hernias, and then remove the needles. And another group, we did not do anything. So here, the patients were done under spinal anesthesia. So the intraoperative sedation was significantly more, while the postoperative scores were significantly less in group acupuncture. So that was the advantage of acupuncture as a preemptive analgesic. See here, a preemptive analgesia treatment reduces post-op pain, opioid consumption, PONV, delays rescue analgesia. So all these things are available with preemptive analgesia. Reducing at once. Now there is a term called preventive. It should be very clear. Preventive is not equal to preemptive. Maybe preemptive is a part of preventive. Preventive means, for example, now you are given an epidural in the post-op period. Now, after 4 hours, he is going to get pain. So, at 3 hours, you give ketamine. That is preventive. But incision has already been made. So, that is preventive. So, preventive includes preemptive. It is not that preventive means it is before the pain patient gets, before the patient experiences pain. That is what is the meaning. It doesn't mean it should be before the surgical stimulus. Preemptive analgesia provided better pain relief than preventive. And rescue analgesics. That is what is another study. Preemptive analgesia can reduce pain up to 8 hours. You can see this is published in 7th May 2025. Now there is a new definition. What we told was administration of a pharmacological intervention before the surgical stimulus or before the noxious stimulus. Now, what is the definition now? So, anti-nociceptive treatment. Many people will think, what is this nociception? Whatever I have understood, I will tell. Now, nociception is equal to pain, but nociception has not got much of emotional components. Pain has got emotional components. Nociception is the word which automatically used for research, as there is no emotional component in this. Now, nociceptive treatment, we are giving an analgesic treatment, which prevents establishment of altered sensory processing of afferent input. Now, you are giving a paracetamol or ketorolac before the incision. What it should do? It should prevent establishment of central sensitization. That is what it should do. Otherwise, it is not preemptive analgesia. Establishment of an effective analgesia is paramount. Very simple. Now you have induced the case of a gastrectomy. You have put in an epidural. Okay, the surgery is not started. You have put in a thoracic epidural and give some 6 ml of 0.15% bupivacaine and start the case. So this is not good because your anti-nociceptive treatment epidural is not full-fledged. Effective level of analgesia is not reached by giving 6 ml of 0.15. So that is what you should give. Minimum analgesia requirement is 0.25. Get the level very well, and then you start the case. So that is effective level of analgesia. You start giving fentanyl or morphine and ibuprofen, IV, and then start effective level of analgesia. The second requirement is key inflammatory media should be inhibited and nociceptive input blocked well into the post-operative period also. You should continue the treatment into the post-operative period. That is what is that, because it clearly tells an anti-nociceptive treatment, analgesic management that prevents central sensitization. That means we need to give the block. We need to continue the block. We need to continue the analgesic treatment into the post-operative period also. There are a lot of doubts about how this and whether this is preemptive. But so far, a lot of trials, a lot of surgeries, spine surgeries, dental surgeries, so many things, it has been established. Actually, we don't advise patients to take NSAIDs before dental procedures. All my slides are downloadable and freely editable in painfreepartha.com and my YouTube channel, Pain Free Partha.